We're going to turn now to an I-Team update. A Queens Children's Hospital says it's seen
There has been a sudden surge in cases of a serious mystery illness in children we've been telling you about, believed to be related to COVID-19.
64 children in New York have now been diagnosed with what is being called pediatric multisystem inflammatory syndrome, believed to be a response to COVID-19.
I understand why parents would be anxious. I think everybody should be.
The rare complication marked by fever, red eyes, rash, or upset stomach, and in some cases, cardiac arrest.
Pattern of life-threatening inflammatory disease in children is really starting to bend the previously held perception that children do not get very sick from COVID-19.
Really is as horrible as it sounds. There's inflammation of every organ of the body. Usually what people see first is the skin, but the thing that we're most afraid about is it affects the heart, and inflammation of the heart is always dangerous.
Hello and welcome everybody to another episode of Sci Talks 2.0. Today I have with me again Dr. Priya Soni to talk about an important issue that has come up recently, which has been defined in some instances as Kawasaki-like illness or systemic inflammatory syndrome. The terminology is constantly changing, but this is one of the reasons she's on today to describe to us what it's about. She's a foremost expert on Kawasaki disease, studies it. She's a pediatrics infectious disease doctor. And so she is the right person to be discussing this issue with the people in terms of understanding what this entity is. So without further ado, if Dr. Soni, can you please tell me a little bit about yourself for the audience? And then we could start talking about what is Kawasaki disease? Is this Kawasaki disease? Or if it's different, what makes it different, and the treatment strategies.
Great. Hi, everyone. Thank you for having me again and welcoming me on. So I just thank you so much for the introduction, Akop. That was lovely. I will add just that Kawasaki disease is my area of clinical translational research interest. So, this is really crazy time for us as we're trying to put together all the pieces of the puzzle with these new concerning features with children and COVID. And so at the moment, in studying Kawasaki disease, there's a lot left for us to uncover. So I'll just give you all a little bit of background on Kawasaki disease for those who may not be as familiar. Well, essentially it is a syndrome that affects children, and it is the most common cause of coronary artery aneurysms and abnormalities in children in the United States. This is a syndrome that is made based on a clinical diagnosis, so there's no blood test that we can give to children to figure out if they have Kawasaki disease or not. So with that being said, this is a clinical diagnosis that physicians have to make. Usually they consult an infectious disease specialist to help with that when you have concerning features in children. So Kawasaki disease is been around. We've known about it for 50, 60 years, and we still haven't figured out exactly what is the trigger for this particular entity and this inflammatory syndrome that causes such issues in the heart for children. And we know that there's probably a multifactorial sort of effect going on that causes Kawasaki disease to occur in children. So first, you'll probably have a vulnerable host, a host that has some genetic predisposition. We know that there's certain genotypes that are associated with having more Kawasaki disease. And we know that geographically where you live makes a big difference. So your genetic background, which is your ethnicity, particular genotypes or SNPs that may be present in you and where you live. So the incidence of Kawasaki disease is much higher, notably in Asian countries. So like in Japan, for example, where Dr. Kawasaki first noted this syndrome, 50, 60 years ago, the incidence of Kawasaki disease is about 200 per 100,000 children, whereas here in the States, it's more like 20 per 100,000. That being said, we have still so much left to uncover. And I will say that while this is all unraveling with COVID and this inflammatory syndrome that appears like Kawasaki, has some Kawasaki features, we naturally see that there is an uptick in Kawasaki cases around the springtime anyway. So I feel like that's sort of clouding the picture as well. We're naturally going to see an uptick in Kawasaki disease cases in the spring and in the fall, which leads us to believe that really there might be some sort of infectious or respiratory trigger involved with creating that syndrome. So
I have a question really
yes,
quick.
ask me.
So then when we're seeing these spikes that are being reported of this illness, which we'll discuss whether it's Kawasaki or not, how can we tell whether it's a spike because of the seasonal, surge that we normally see with Kawasaki around this time, or it's a completely new entity? I mean, what's the data suggesting that, hey, this is a different kind of a spike and we're seeing more patients, or the symptomology is different?
Well, I think we're going to get into that. I really want to talk to the audience about some of the features of this new multi-system inflammatory syndrome in children, as the CDC has now called it or coined it. Let's not get too attached to the titles. As we know, these names are changing every week. So we'll have to see what they finally agree on. But yes, there's certain distinctive features that we are seeing in these kids that have this inflammatory syndrome after COVID. It's completely different than Kawasaki disease. So that's why it's really important for scientific community to come together and to really share the information about the cases that they're seeing. And so I encourage any of you who are watching this, who are physicians that have children that you're seeing in your clinics, offices, hospitals, with some concerning features, to reach out to me to talk, and maybe we can talk about what you're seeing too. So I want to answer your question a little bit more, but let me kind of tell you, or the audience, give them a little background on how we make the diagnosis of Kawasaki disease. So essentially, it's based on you have to have at least 4 out of 5 clinical criteria for this diagnosis to be made. And I'd love to kind of share some screen, or maybe we can just talk about it quickly, I guess. The clinical criteria are 5 distinct ones. One, in that there is potentially cervical lymphadenopathy. Usually it's unilateral, very large lymphadenopathy. That's one. Number 2, there's some sort of rash. So that will be like any type of rash really can be considered, but it's usually a polymorphous rash. Number 3, swelling of hands and feet. And potentially peeling of skin, so desquamation of skin. And that's something that we see in toxic shock syndrome too, so that's something, to keep in mind. But essentially these 3, plus let me just make sure I'm not forgetting anything, but conjunctival injection. So you have to have bilateral conjunctival injection with, usually it is limbic sparing. So it's a very distinct pattern of conjunctival injection.
So just for the non-clinical audience, that means redness.
Redness of your eyes, yeah. But it actually spares the part right around the colored part of your eye. And so it appears white immediately around the colored part of your eye, but the rest of your eye is completely red, and it must be bilateral, and it must be present without any pus or drainage. So no, a lot of times in the spring we have allergic sort of redness of our eyes because of seasonal allergies, but it's very different from that, as well as it's very different from a bacterial infection in your eyes, in that you don't see any yellow-green drainage or discharge. So that's a really important distinction for this. And then I got the, oh yes, the last criteria is inflamed sort of oral mucosa. So you might have some red cracked lips or even like a strawberry tongue appearance in these children. So that's the clinical criteria. And so you must have at least 4 of these features in the presence of 5 days of consecutive fever above 100.4. In addition to this, you know, we're not going to get into the criteria for incomplete Kawasaki, but there are certain times you can make the diagnosis of Kawasaki disease based on 2 or 3 criteria, but with the additional supplemental laboratory findings. Some of those include albumin, low albumin, or sterile pyuria. So these things are just lab findings that we can see to support the diagnosis when you only have 2 or 3 criteria present in the child, but you've had fever for more than 5 days. So I know that's a lot of talking.
That's a lot of pertinent information, and I think the audience really would appreciate that. So when you're making these diagnoses, just to be clear, there's no specific, even though you mentioned laboratory tests, there's nothing specific that you could measure. It's more like clinical plus some supporting findings of the lab, right? And does age matter as well?
Absolutely. So what we know about Kawasaki disease is that it typically affects children less than 5. You know, the average age of onset is around 3, and 50% of cases are found in kids less than 2 years old. And something to really keep in mind is that when you see Kawasaki disease features in a child that's less than 12 months, they're at a higher risk of developing these coronary aneurysms or coronary artery abnormalities that we know. So I think that's a very important distinction as we talk about this new thing that we're seeing. Okay, so
a couple of quick things. What is does it self-resolve, first of all? Second of all, what are the complications we worry about? And what is the treatment, just really briefly, for Kawasaki? I know this isn't exactly what the disease is, but just for distinction purposes and whether treatments are going to be different for this new term.
So for distinction purposes, I will just mention that, you know, the recommended gold standard of therapy is to get these children, identify these children with Kawasaki disease, and to provide the mainstay of therapy, which is IVIG, pooled immunoglobulin, and to give that within the first 10 days. You know, that's really our goal. And most of the time, kids respond beautifully. The fevers go away within 24 hours. They're very, you know, complete change in their demeanor. Now you have a subset of patients that are IVIG refractory, and then we have to try other methods. Sometimes we give another round of IVIG, high dose IVIG. Sometimes we try other medications, immunomodulatory medications, so things that affect the inflammatory cascade, like infliximab, for example. And the whole goal of the treatment of Kawasaki disease is to prevent those coronary artery aneurysms from you know, either developing or getting worse, right? Because this is something that would affect the child for the rest of their lives. I think a lot of research has come out about how Kawasaki disease, that you see adults that get, you know, myocardial infarction less than age 40, and about 5% of them have history of Kawasaki disease that was undiagnosed and have some, you know, internal weakness in their coronaries that has predisposed them to have a cardiac event. So I think
And
it's
and how do you monitor these people? Typically with
yeah.
echocardiogram?
So we get echocardiograms on these children early on in the course and during the process of making the diagnosis. If you see a coronary artery abnormality, even dilation in the coronary, in the coronaries, that's really clenches down on the diagnosis, even if you don't have all of the criteria fulfilled. And thus, you know, we're getting echoes on these patients right when they come in to the hospital, and then we follow up with echoes because the coronary artery abnormalities can develop later on down the road too, in a small subset of patients. So really and truly, these kids get monitored for a long time. We follow them in our clinic. We're very invested in how their cardiac function improves. They're hooked in with cardiology right away. It's a very multidisciplinary approach when we diagnose and treat and manage these children.
And so kind of going towards the topic of coronaviruses, not the SARS-CoV-2 yet, but I know that there's some research suggesting that one of the triggers of Kawasaki could be the family of coronaviruses, which causes the common cold. Do you agree with that as being a major trigger, or are there other significant features besides ethnicity and location of geographical location?
Well, we don't know. I don't think that coronaviruses specifically are triggering Kawasaki disease. As you know, there are multiple different coronaviruses that cause the common cold. And also we have influenza every year, right? When we see an uptick in influenza cases every winter, we don't see an uptick in Kawasaki disease, right? So I don't think all respiratory viruses are capable of, you know, creating this sort of perfect storm for Kawasaki disease. And coronaviruses like SARS, in 2003, it was speculated that it could be triggering Kawasaki disease. We were having that same debate, you know, a decade ago. So I think at that point it was dispelled as well that it is not related directly to cause it. But I think there's still a lot we don't know about how the immune system functions and what causes it to go into overdrive, into some of these hyperinflammatory states that can cause sort of a Kawasaki-like picture, but I think it's a misnomer to say that it's Kawasaki disease, because I'm going to tell you it's very distinct what we're seeing.
So let's then come to what we're seeing now with the kids with COVID-19. You've beautifully described the clinical features and the laboratory findings of typical Kawasaki. So what are we seeing now, and why was it initially called Kawasaki-like, or was there a confusion? Because I mean, just because we have a pandemic doesn't mean kids with Kawasaki are not going to come in, right? So was there a confusion about that? So, and how can we distinct them?
Yeah, I think that, you know, semantics and our wording is very important in this time and era where we're getting information literally shoved down our throats in all different avenues, and it's really easy to categorize this new thing in Kawasaki, like as a Kawasaki disease type syndrome, but it's very, very different. And the reason why is because, well, I'll tell you why it's similar first. How about that? So it's similar because these kids are coming in. As you know, when kids get COVID, nobody really knows. A lot of times they have very mild symptoms. Many of them are not getting tested with the PCR at time of mild symptoms, right? And so they're coming in a few weeks later and they have red eyes, they have fever. So you can see a couple similarities. They're having peeling of their hands and feet. they're having, with Kawasaki disease, I didn't mention this before, but sometimes in Kawasaki disease, initially the kids can present with some vague abdominal pain. But these kids with the multi-system inflammatory syndrome associated with COVID, they're also coming in with abdominal symptoms. So those are some of the similarities, but this new entity really fits more in the category of like toxic shock syndrome than Kawasaki disease. So a lot of people don't know that toxic shock syndrome, can happen after you get a staph or strep infection, and then you get this super antigen that sort of causes this inflammatory response. It looks very similar to what we're seeing here in these kids. So let me just go through why it's different than Kawasaki disease. It's different because the age that these children have been reported with this syndrome, this new syndrome, are much higher than the Kawasaki disease patients. As I mentioned before, Kawasaki disease kids, usually around 3 to 5, that's the average age of onset of Kawasaki disease. These new kids are much older. They're average age of 7.5, even 11, 12 years old when they're coming in with these symptoms. And the next thing is that these kids are coming in with severe abdominal pain. They have more GI symptoms. A lot of times our colleagues, that have seen this firsthand in Italy and the UK, they report that these kids have such severe abdominal pain that it's almost mimicking appendicitis. It's that severe. That's just not what we see in Kawasaki disease. Some of them have some neurological findings, so they'll have some CNS, altered mental status, and things like that. It's different.
A quick question about GI issues. Is it associated with diarrhea, constipation, or is just abdominal pain?
Abdominal pain, that's really what we've seen. I can't speak to whether it's more diarrhea or constipation in those kids. I'm not sure. But the abdominal pain seems to be distinctive. I believe it's diarrhea, but don't quote me on that. As in toxic shock, we often see kids that have diarrhea. This again fits more of the toxic shock sort of picture, not KD. Some other distinctions is that, there's some laboratory findings that are very different, and my mentor gave a great talk on this, but I'll just mention some of the distinctions that he told the audience, one of which is that there is a big difference in the lymphopenia. So the lymphocytes are they're dropped off in this, potentially COVID-related inflammatory syndrome in kids in comparison to true Kawasaki disease. Kawasaki disease, you see a very high white count, and you don't see lymphopenia, which is a type of white cell, being very low. The other distinction is that in kids with this new syndrome, we're seeing them have more of an increase in their BNP, which is often measured for cardiac reasons, but this is very different than Kawasaki disease. And then one major thing that I think is huge, because in Kawasaki disease, we always note that the platelets get super high. The platelets are above 450,000 often. But in these kids with the new syndrome, the platelets are low. And it's very, very odd, but it doesn't quite fit the picture of classic Kawasaki disease in that sense, that the platelets are just so low. And so I think it's important to highlight these differences and to let physicians know that there are some major differences here.
So clinically, they could look the same, but pathophysiology-wise, it sounds like they're quite distinct in terms of their features. Now, it sounds to me like the adult form in terms of the lymphopenia and the platelets, but it's very delayed. In the adult, it's happening through the progression of the course of the disease, but it seems like in kids, it takes after the fact, like 2 weeks for this to sort of present itself. So, and we know in toxic shock, it can happen weeks after, right? So is it similar to the adult in terms of the pathophysiology, or we're just seeing the same clinical laboratory findings, but the driving force is completely different in your opinion?
I think, with the adults, we usually see this pattern where they're doing fine, right? They seem to have some mild symptoms, they're trucking along, and around day 7, they sort of take a downward turn sometimes. So from my reading and, the lectures and things that I've heard from others, it seems like in adults, the innate immune system seems to provide some sort of initial protection. But then it just can't handle the virus. And then in the second week, like at day 7, it's when your T cell response and your cytokine storm sort of ramps up and thus causes that out of control response to this virus. With kids, it's hard to say, why is this happening much later? Is there something about the virus that we don't know yet about how it binds and causes this dysregulation in the immune system that happens much later, 2-3 weeks later? So is it similar to toxic shock? Like you were alluding to, toxic shock can also happen much later after the initial exposure to bacteria. Is it behaving more like a bacteria? Is there some sort of molecule that we need to figure out that kids are potentially producing, some kids are producing, that is driving this cascade to happen? So I think we still have a lot to learn.
In adults, it's typically respiratory, but are the kids, presenting with respiratory issues? I've not heard of cases where they need to be ventilated. It's more about affecting the heart. So
you're absolutely right. I want to just say one thing. In the grand scheme of everything, we can still say that kids are still not as affected as adults because of COVID, right? Data from CDC shows that children, there's about 2% of all positive COVID cases that are in children less than 18 years of age. So overall, we're talking about a very, very, very small subset of patients that are getting this. But you're absolutely right. When they do get this syndrome, it's not that they're having respiratory failure or respiratory symptoms that cause them to go to the pediatric ICU. They're actually having these abdominal symptoms and other abnormalities. Renal system is involved, CNS issues that drive them to be admitted. So that's a really important distinction. Thank you.
And just to follow up on that, I'm a little bit hesitant in terms of saying kids are not my point is that I wish most kids displayed symptoms so we know to intervene and treat them, because I'm wondering how many kids actually can have the disease, get the infection, but not present overtly with their symptoms. So later on down their lives, the complications, just like you were mentioning people with Kawasaki, right? They can have coronary artery aneurysms. And I'm wondering, when we say the kids now, they don't look symptomatically bad, but I'm wondering if later on they're going to develop some really severe, issues like coronary artery issues. We're talking about kidney function, neurological stuff, and so should we be testing kids more just so that we could pay more close attention to this? Or you think because pathophysiology wise, it's not like Kawasaki. We shouldn't worry so much about the coronary artery or systemic issues as much.
I think you're totally right in bringing this point up and saying that, we should be following these children. We're dealing with a completely new entity. And, Kawasaki disease, we have the advantage of 50, 60 years of research. We're talking a few months for this pandemic and COVID-19. So any follow-up of these children is going to be crucial in trying to piece together this puzzle that's still very fresh. So we need to really follow these children and make sure that they don't have long-term complications that we don't see initially. And that's why one of the beautiful things, I'm such an optimist, as you can probably tell through this whole thing.
The pediatrician in you.
Exactly. One of the things is that's beautiful that's come out of this is just the amount of scientific inquiry and registries amongst pediatrics and collaboration in trying to figure this out. And this is a really terrible time, but it's also a very exciting time for science. And we have to rely on each other. So I really encourage that collaboration.
So let's discuss about treatment, right? We know kids with Kawasaki, you give them IVIG. So what's the sort of treatment strategies for kids with, let's just call it multisystem inflammatory syndrome for the time being? And are there any diagnostic things that we need to do, imaging, for example, to help figure out if there's issues that need to be followed?
Yeah, so actually the CDC had just put out an official document on what physicians should look out for. And we can, potentially share this with the audience. But they've set out some clinical criteria for physicians to look out for. And at the moment, they're saying, if the patient meets classical criteria for Kawasaki disease, we need to continue to treat them with the IVIG, go down the same pathway that we're used to, right? But in certain cases, for example, about a third of the cases that are seen have PCR positive for COVID-19, for example, in these kids. In those cases, we have to kind of maybe think outside the box. Still, if they meet the classical criteria for KD, still treat them for KD, but work with your multidisciplinary team to potentially, if the kid is really sick, to provide some alternative therapies. And if there's concern for active COVID, but that's not what we're seeing here. You know what I mean? This is very different. Most of these kids, they look like Kawasaki disease, they act like Kawasaki disease, and they are, because we're seeing that uptick in the spring, as I mentioned. But there are a small subset of those that look like Kawasaki disease that somehow, when you test their serologies for IgG, have COVID positive. So that's where the confusion is coming in. And I think, if it's toxic shock, if it looks like a duck, acts like a duck, it's a duck, right? So
Right.
Toxic shock syndrome, that's a completely different management. And so we have to keep that in mind too, that they may look like toxic shock and actually have toxic shock, which is treated with antibiotics as well as IVIG. So we just have to kind of be really, really careful as clinicians about correctly diagnosing these children, and not letting,
A
the
PCR
media,
positive test for
PCR,
COVID.
yes, let's synthesize and think about this before we label things as being causing. Correlation does not equal causation, right? So we have to keep that in mind.
I know you were involved in a pretty big interaction with multiple groups internationally. What's the general consensus worldwide in terms of how worried should clinicians be to keep an eye out for this? How worried should parents be? And, you know, what does this mean in terms of opening up schools and letting kids go back and interacting? Because for now, people assume kids are fine going back to school as long as they're not carriers, you know, but it's not a problem. But if there is a significant issue, that would need to be kind of readdressed. And
Yeah, I mean,
sorry, and I know it's a lot of questions and it's loaded, but because this is an interesting topic. And why are we seeing this come up now in sort of you know, pretty late stages of the pandemic, I would say? Why weren't we seeing more reports coming out sooner, or what's the delay in us knowing about this?
well, I think I'll start with that one then. I think potentially the delay in us knowing about this is that there have been zero reports of this happening in China, where the pandemic started. I will say that, you know, there are no notable cases of the syndrome occurring in some of the countries where KD is very high, the incidence is high, like in Japan, China, you know, South Korea. We have not heard of those cases like this occurring there. This is more distinctive and different in that this alert and this worry came about as it was alerted to us by physicians in the United Kingdom, in the UK. And that set off an alarm. And then you look at countries like Italy, there's a pocket in Bergamo. And, you know, we talked about this paper, you and I, that just came out yesterday, or the day before, about the cases coming out there. So these are pockets in UK, in Italy, and now in New York. So that leads us to pause, you know, could there potentially, you know, I'm just hypothesizing, but many people have thought, you know, could there be a different viral strain that's driving some of this new inflammatory syndrome that's different than the strain that came out of China, for example? You know, we haven't seen very much of this syndrome on the West Coast. So I will say that, you know, something is going on, you know, UK, Italy, East Coast, that's very different than the West Coast. And we know through the epidemiologists that have been working very hard to track this virus and the mutations that this virus is having. There's not very many, but do hypothesize there might be a different strain of virus that's potentially driving this in that particular region, the regions that I mentioned, that's different than the one that came out of Asia that's affecting more of the West Coast. So I think we still have a lot to figure out, and it's very, very exciting. I think parents should continue to be very careful with their children, monitoring them and making sure they don't have prolonged high-grade fevers. And some of these symptoms, I think the beauty of this is that people are more aware about Kawasaki disease now. So maybe we'll miss less Kawasaki disease, you know, for the next few years, because we're very alert as to what the symptoms are of Kawasaki disease. So to be on the lookout for that, but do not worry, because this is a very small subset of the overall 2% of the population of pediatric patients that's being affected by COVID. So though the news is sort of hyping it up, this is why, you know, we're here talking about this off the cuff, is just really and truly it's isolated cases, and it's less than 100 right now in the United States that I know of, but that may change. We'll have to see. Continue to do your best, I think, to quarantine and stay at home. And the question about schools opening, I think, is a good one, but I don't think we can open schools until we have a good serological test and, you know,
So,
that's
so you're
available. But
saying
if
this
it,
shouldn't affect that decision. It's a whole nother ball game in
well,
terms of
we
figuring.
could talk for another 2 hours about my thoughts
Yeah.
on serological testing. I'm sure we will. But
Yeah.
I think uh, serological testing is key to opening up schools because we need to know how many of these kids with mild symptoms truly had COVID. We need to know the prevalence of COVID in our communities and our population before we start loosening the reins on things, because what's going to happen is it might get better for a little bit and we'll have that false sense of security over the summer, but this could potentially, and I definitely think we're in for the long haul, and that it's going to get worse come fall when we see more respiratory viruses overall anyway.
I see. So just one couple of last quick questions. So right now you're saying in terms of treatment, if it's Kawasaki IVIG, if it looks like toxic shock, treat it like toxic shock, and if it's somewhere in between, based on the laboratory blood work, either anti-inflammatories or immunomodulators for the time being.
Yeah, and there are multiple groups working on putting together more refined criteria and treatment guidelines for this. I know many of the Europeans are also adding steroids to the IVIG, which they really have found to provide some protection against formation of the coronary artery aneurysms and abnormalities. So that's something that's a little more controversial in the United States, but that's a potential as well to consider. But I think we need more data, and we need more time to tease out those fine details.
And so you don't do echo like for all the patients, or do you still do echo if they come in?
I mean, if they meet the criteria for KD, we go ahead and echo, but we don't need to be echoing every single patient, at this point if they walk in with a fever. So.
Okay. I know I don't want to take more of your time. So if you have any last few words before we call it a day for today's episode, and then I'll probably see you again in the future to talk about the serology and opening up schools, and hopefully with some more information about this. But any last few thoughts?
Yeah, last few words is that, we can definitely share the CDC case definition at the moment. That might change, but let's provide that for you all. And I just wanted to say thank you all for tuning in and listening. I think this is a great platform, and we hope to be, continuing to give you good information. And I give credit to Akop for setting this up. Thank you so much.
Thank you. I really appreciate it. And with your permission, I may even put your contact for those physicians that want to reach out if they're seeing kids with this, to have a discussion and perhaps a collaboration.
Yep, sounds good.
All right. Thank you so much, Dr. Soni. And you take good care of yourself, and I'll see you on another show.
Take care. Be well.
Bye.